Thank you, Brenda. Pleasure to be here, and again, pleasure to be with fellow clinicians and those facing the challenging times we have. I remained active in 2 wound care centers here in Jacksonville, Florida. And as you all know, as we appreciate, healthcare, wound care remain essential services. So our clinics are open. We're seeing patients. The volume has diminished a little bit, though, and understandably in regard to the concern around the virus. So we're still seeing patients. We are providing the necessary care, but we are getting cancellations for patients who either physically can't or emotionally can't envision themselves being in the wound care center. So care goes on, but the challenges go on as well. Well, speaking of challenges, as Brenda highlights, we truly are in unprecedented times. And we've never faced this. I certainly have never faced this clinically. I would assume that you haven't as well. And so we've got to think differently. I think as a community of wound care providers, of lymphedema therapists, we've got to think differently about what our patients need and how we can deliver that care more consistently and choose venues for the patients that meet their needs at this challenging time. So this obviously reflects our observations, those on the call, but also from the AAWC, the Alliance of Wound Care stakeholders. So next slide, please. Lee Rogers, representing the Alliance of Wound Care stakeholders, represents the similar view, and quite simply that we are in these challenging times, and it's not only reasonable but appropriate and sometimes life-saving to manage wounds in different places. If we're patient-centric with regard to our consideration, if we can avoid those unnecessary ER visits and hospitalizations as a result of a deteriorating wound or a cellulitis or some clinical challenge, then we truly are doing the patient a greater service than ever. So next slide. So I want to spend time really thinking about a couple of different etiologies, and more specifically, venous leg ulcers and the edema association with that problem. We know that venous leg ulcers are the most common lower extremity wound seen in the outpatient center. So we realize the impact with regard to the number of patients. We on the call who take care of these patients, and I know many of you do, realize the clinical challenges, the necessity for frequent, appropriate, aggressive, patient-centric, and driven care to get the best outcome. Obviously, DFU is a major clinical problem for our patients as well. We know our population in the U.S. is somewhere around 10% or 15% of patients, Americans, are diabetic. And some quick math around that would tell us that 1 in 4 develop a lower extremity wound at some time in their lifetime. And so we see the tsunami, if you will, the ongoing tsunami of both of these clinical challenges in this time that we face together. So next slide. Let's think about venous leg ulcers if we could. And again, this is a review for the vast majority of you on the call. We know that these wounds are obviously lower extremity wounds and typically occur in what we described as the gaiter area, somewhere between the mid-calf to the heel. The wounds are shallow, they're irregular. Exudation, wound exudation, weeping wounds are very common and very problematic, and these are painful wounds. Patients are suffering consistently and regularly as a result of these clinical challenges. Let's go to the next slide and dig in a little bit on etiology. We know, in essence, we're talking about a valve problem, right? It's a mechanical problem with the vein. And we know that the blood flow typically is unidirectional in a normal vein from south to north, and we prevent backflow of blood by the bivalvular structure of the veins in our legs. When these valves no longer work or don't function in a fashion that promotes unidirectional flows, you can see in the upper right-hand corner, then we result in, or we see clinically, retrograde blood flow. The blood doesn't leave the leg. This leads to venous hypertension, or an increase in the blood pressure in the venous system within the leg. Well, our veins really aren't designed to manage that level of pressure, and we know that, and they leak. They quite simply leak fluid, and they leak what's inside the blood vessel to the outside of the blood vessel. Clinically, this occurs when we see red blood cells leak out of the vein, and they break down much like a bruise would break down, creating that typical brawny or brown stained or bruise, almost a bruise type appearance of the leg. Lipodermatosclerosis likewise occurs in association with the combination of fluid loss or plasma loss plus the activation of white cells in the extravascular space. White cells don't like to be outside of blood vessels. It tells them, hey, we've got an invader, an intruder, and they release a variety of collagenases and elastases, which can be very traumatic to tissue. So it's the combination of acute and chronic inflammation that ultimately leads to tissue injury and the development of a wound. So next slide. That lays the foundation, if you will, for why we develop venous leg ulcers. Let's take that step or take that consideration one step further and think about the role of edema and how we manage edema clinically in the setting of venous leg ulcers. We know that there is a delicate balance at the capillary level between filtration or loss of plasma outside the blood vessel and then reabsorption. And there are approximately 30 liters of filtration followed by 27 liters of reabsorption on a daily basis. So we manage that very well dynamically. We know that the lymphatic system is critical to manage the overage or the overrun or the imbalance of fluid to keep us in a state without edema and a well-functioning limb. We know that it's pretty easy to perturb that balance. So venous hypertension, as we talked about, can lead to, in essence, a backflow issue. So contributing to the worsening of the lymphedema and then primary lymphatic disease as well. I know Karen will comment on that in just a couple of minutes. So let's go to the next slide, if you would. Okay, so how do we take care of venous leg ulcers? And again, I'm respectful for the notion that I'm really speaking to experts in the room, and you guys have been managing these wounds classically for a long time, and you get it. But let's just remember that there's some foundational activities, some thought processes that we need to think about in managing venous leg ulcers. And the first is compression therapy, right? We're counteracting the force, the distensible force of these diseased veins. So using a multi-layer wrap or short stretch or a Uniboot type wrap or a Duke boot type wrap. And then very importantly, pneumatic compression systems that we'll hear about today are foundational in managing not only the lymphodematous concerns, but the venous hypertensive concerns as well. Appropriate and well-timed debridement, dressing selection application to manage the microbiome of the wound, to manage the excessive drainage we see in these patients is critical as well. We know there are various medications that are beneficial, pentoxifylline or Trental, doxycycline, there's horse chestnut seed extract, aspirin on a daily basis, and a variety of medications that are beneficial as well. And then once the wound's under our control and we've managed the edema, we think about closure opportunities, either with autologous skin grafting, maybe a cellular-based tissue product, or a placental product that are commonly used as well. And then lastly, dealing with the underlying venous issues. So it's endovenous closure to manage the superficial venous incompetence that is fueling these underlying wounds. So let's go to the next slide, if you would. Okay, so we understand what we're taking care of. We understand the pathophysiology of edema and venous leg ulcers. So where are we doing these things? Well, we know right now that there are a variety of programs, outpatient wound care centers, that involve a variety of different skill sets. Perhaps even on this call today, we have vascular surgeons, podiatrists, we have WCN nurses or nurses with advanced training in wound management. We have lymphedema therapists, physical therapists who understand and are critical in proper wound management as well. So limb salvage program, points of care to include not only wound care centers, but inpatient service, skilled nursing facilities, LTACs, even burn centers are getting in on the wound space as well, and then home care, right? We only see our patients in the wound center a day or so a week at most, and these patients need more frequent care. So involving our home health partners is critical as well. Next slide, please. And so we get it. We realize that what we're doing, what we're delivering actually works. So wound care centers are becoming very popular. If you look at 2003 to 2017, we see what I would perceive as an appropriate understanding and need for advanced wound care of this type that occurs in wound care centers and in the venues that I've previously mentioned. Next slide. But here's the challenge, and we know this interesting fact from the standpoint of looking at large patient populations. We know demographically, if you look at a disease segment of our population and tied to their age, that we should be seeing a significant increase in the number of patients with venous leg ulcers and diabetic foot ulcers in our outpatient care venues. And the reality is we're not. We're only seeing about 10 to 20% of the treatable or the allowable or the addressable patient market within these points of care. And the question is why? And I think, you know, we've begun the call around the COVID challenges, but we were seeing this before COVID as well. So let's go to the next slide as we think about the deficit and understanding. And as we do so, let's think about the cost of what we're talking about. Let's think about the cost of what we're talking about in terms of success and failure. So here's a very interesting study looking at the real cost of venous leg ulcer management in a vascular practice in Boston. This was Dr. Ira Frady and Tom O'Donnell and his group, and they looked at 84 patients over a 6-month time period. And looked at the average cost of treating patients with venous leg ulcers, $15,000. When they were successful, the cost was $10,000. 17 of the 84 patients, though, didn't heal within that 6-month time period. And I know you, if I know you and you're like me, you've got those patients that you've had for well longer than 6 months. And in point of fact, they're still not healed. Well, the unhealed patients in this study were 3 times more expensive than the patients who healed. And the cost contributing factors were obviously outpatient facility fees, visiting nurse costs, and then inpatient management. Inpatient management is very expensive, and it's really expensive now as we think about the consequences and the challenge in the COVID world about putting these patients in the house, in the hospital house, and actually providing care. So not only is it very expensive, it's very risky, and I think we need to be thinking about other opportunities as well. Okay, so I think if I've done my job, I've laid out the problem, right? The problem is we've got a very difficult challenge on our hands. Managing complicated venous leg ulcers and diabetic foot ulcers on a regular basis is a major concern and a major opportunity for many of us. These are complex, highly morbid patients who require advanced products and advanced services and individuals who understand the needs and the timeliness of care to get the best outcome. But here's the challenge. Right now, we're still managing patients according to venues, right? I think we're still asking the patient consistently to go to a place and see a provider, go to a place and get a thing done. You know, you've got to arrange transportation. You know, my parents passed last year, but I will tell you, my dad bemoaned regularly about being an older patient was a full-time job because either he was going to the doctor or taking my mom to the doctor. So we're really adding a significant burden to our already challenged patient population in the way we're managing care currently. Well, let's go to the next slide. So I think I've elucidated care is driven by you know, what we can do to the patient. So we're paid, unfortunately, right now in the fee-for-service world based on the number of things we can do for a patient and the number of times we see the patient, and that drives costs to the system. And I think we could argue provides questionable incremental value to the patient's experience along the way. And in point of fact, we're really talking about not only the patient, but those who care for the patient as well. So primary care providers. It's us on the call who have a unique interest in wound care and edema management, specialists, home health, and wound care centers. So I want to go to the next slide, and I want to think about what do we want to be? How can we think about a better solution? And here's a question that I would propose to you. Can we bring appropriate, well-timed care to the patient in a patient-centric fashion and not a venue-centric fashion that utilizes tools and resources, that utilizes our time and, more importantly, the patient's time to drive the best experience, to limit supply costs, to reduce the episode of care duration, to reduce recidivism, right? These patients are always failing. They're coming back because we haven't done our job, or they haven't done their job, or their disease has manifest in a different way. So that's the question. And I would suffice to say that there isn't an answer, but I would ask you to begin to think with me, to begin to think about what opportunities might look like, not only in the COVID world, but in the post-COVID world. Are we going to do things differently or think differently about how we manage our patients given the information that we have now and the high likelihood that we'll have challenges of a similar nature going forward? So this slide sort of depicts some thoughts that I've had around how we could utilize telewound care as a valuable patient-centric tool and pull in others to support the process, but all the while making the patient the focus of our care. So you can see weeks laid out here. So week 1 would be where the wound care physician or the expert in wound care actually visits the patient's primary care physician with the patient there, either scheduled or de novo, evaluates the patient, has an exchange with both the provider and the patient, and assumes or manages the patient going forward. Week 2 could be a virtual visit. So at this point, the patient may not require a physical examination. It could be a check-in. It could be a skin tear. It could be something minor where, again, we have the opportunity to manage distantly and then keep everyone in the loop with regard to the reporting process. Week 3 might be an opportunity to have home health, or maybe home health has already been partnering with the care of this patient. So having a virtual check-in between the provider, the wound provider, the home health team. Maybe it's time to enroll a specialist to provide an additional service, or get on the schedule of a specialist without actually having to have seen that specialist or waited in that specialist's waiting room. Week 4, where we have the opportunity at some point to have a face-to-face encounter with the patient. Maybe this is the first time they come to the wound care center. Maybe this is the first time they need an aggressive debridement. Perhaps we've used an enzymatic debrider or some other product along the way to facilitate an effective intervention at the right time for the right patient in the right place. Next slide, please. I'll summarize my comments or conclude my comments with this slide. This was a recent publication by David Armstrong and Larry Lavery, Warren Joseph, and some others from the American Podiatric Medical Association. And I was very pleased to see this, in that there's an understanding about the priority and the triage, if you will, of patients in our COVID world. So suffice it to say, this slide says that for patients who have wounds that are clinically stable or are guarded and perhaps maybe serious, let's try to keep those patients out of the hospital. Let's try to utilize telemedicine. Let's utilize home health. Let's utilize the safety of our own offices, provide necessary care, and then only when possible, advance that patient's level of care into the hospital setting. And so I think we all think this way, but I think now in the COVID world, and hopefully we're coming out of that to some degree, and then going forward, do we need to think differently about who's taken care of, where they're taken care of, and then utilizing our tools and resources and our venues in an appropriate patient-centric way. And with that, I will pass the baton.
a lot of webinars out there. There are other companies as well, and we need to be up to date in terms of what is reimbursable, and I encourage people to do that.
Thank you so much, Karen, for answering those questions. And Emily, if that adequately answered your question, then good. If not, please follow up. I want to go to the very first question that we got. Kathleen Judge posed this, and this is for you, Dr. Covington. Most telehealth visits require a video modality, and a lot of wound care centers don't have Zoom, Skype, iPads, or iPhones to allow the visualization of the wounds. Telephone visits only would be less desirable